intracranial pressure monitoring. What did you learn about that?
There's only one catheter that drains the CSF.
Right. The interventricular catheter is the one that you want because it will allow you to measure as well as to therapeutically reduce or drain the amount of CSF in that brain. Okay? So what are some safety issues that you worry about with someone with an interventricular catheter?
Bleeding, hemorrhage, and successful breathing.
Okay, very good.
And positioning.
Going into it.
Infection. Okay. So as the nurse, what am I going to do to make sure that that drain is appropriately placed at the bedside?
Positioning.
Unplug the bed. Unplug the bed so the bed doesn't move. Level it with the tragus of the ear. Okay. And like I said, most of the time we use either a level or a laser level or sometimes just a stick. It works. All right, so.
Also decreasing the stimulation in the environment,
Right.
so making sure that family are aware of the patient's condition and
Right.
keeping them informed as not to have increased anxiety for them.
Right. Because they feel if you don't have a patient that's paralyzed and sedated, they pick up on negative energy in the room. Okay? So if family members are anxious and crying, it makes them upset. So we want to definitely care for that family because they're as much your patient as that patient is. I'm going to tell you that's one of the things that you're going to see as you go through nursing. Taking care of patients is nothing. It's the family that's going to be sometimes your biggest issue. Okay? So if you get off on the right foot with them and making sure that they're fully informed about what's going on, decrease their anxiety, then it's going to make your life a whole lot easier. Unless I'm your family member, and I'm going to be at that bedside 24/7. Yeah, that's one of those things that no one of my family goes into the hospital without someone with. Because it's, like I said the other day, you're sick, you don't fully understand what's going on, and you need someone there to not only interpret, but to advocate for you. Okay? All right, so, anything else about increasing intracranial pressure in nursing care? Get the bed up. Neck is straight. Midline, straight. Okay? That doesn't mean we leave them on their back. They can be turned side to side. Unless they have what?
They've had a craniotomy.
They had a craniotomy and the bone flap is out. Okay? Remember with that, you typically don't turn to that side. And like I said, you can see the brain pulsing underneath it because there's no bone there. Sometimes those stay out for a couple weeks, a couple months. And no, we don't put metal plates in most anymore. You know, in World War II, that's what they used, but now we use like plastic. Or sometimes they'll even use gabardine. Okay? But you can freeze their bone flap if it wasn't infected and put it back.
How long does it
About 6 months.
The hospital has, like in the OR when we have trauma, we have to sit in the freezer until it has to lay or it's put back in.
Yes.
How long is it usually removed for?
It depends on the patient and exactly what. You know, most of the time it's like a month or two. But I've seen some patients 6 to 9 months. Yeah.
But if you have dichotomies or it's usually like 3 to 6 months before the
Yeah. The other reason that you have to save the those situations is there's going to be a medical examiner case. Okay? So, medical legal type stuff with a lot of my patients, if they were a victim of trauma, like fatal motor vehicle crash, gunshot wound, or assault of any sort, when that patient dies, you never remove anything. If they're intubated, the tube stays in. If the IVs are there, the IVs stay in. You just cut and tie the IVs and send them to the ward like that, so that whenever the medical examiner sees them, they know that that hold is because of an IV, or that trauma may be due to intubation. Everything that's on them when they die, whenever they are a victim of trauma, abuse, and they're going to be a medical examiner case, everything stays on the body. You don't remove anything. All right, so now let's talk a little bit about brain death. What did I tell you about brain death that you need to remember? It's bad. Herniation is a bad thing. Okay? Basically, with brain death, it's a legal definition of death. Okay? Because basically what you've got is a patient with no brain function. And that includes the cerebrum and the brainstem. Okay, remember you have to have that intact brainstem to maintain blood pressure, pulse, respirations. Now, sometimes you will see people that have been termed brain dead, but they're not really brain dead if they've got brainstem function. We call that PVS, or persistent vegetative state, meaning that they will be able to support their blood pressure, pulse, and respiration, but they have no cerebral activity, okay? Which means that they will exist pretty much in that state until they die of something else, more than likely infection from pneumonia or urinary tract infection. Okay, yes.
When they have like locked in, they be considered brain dead?
No. Locked in it's one of those things that horror books have been written about. Think of locked in is very similar to that patient that I told you that had the pancuronic bromide or the pabulon. They're paralyzed, but they're still fully aware. Locked-in syndrome, typically with those patients, they have total body paralysis. They can't turn their head. Typically, all they can do is blink. But they're fully cognizant of their surroundings. They know what's going on, but they just can't do anything. And basically what you do is you set up communication systems with them that like blink once for yes and two for no. Because that's the only thing they can do. And unfortunately, people live in that locked-in state sometimes as long as 20 years. Have no clue what causes it. Sometimes it's stroke, but it's one of those things that's very rare. I've only seen one in my 38 years. And that's probably because I was at Duke at a control center. But it's extremely rare, but it's one of those things that I can't imagine anything worse. Okay, so how are some of the ways they're going to determine brain death? Fixed pupils, doll's eyes, absence of cortical reflex, apnea test.
No cough or swallow reflex.
No cough or swallow. Okay, remember all of those are cranial nerve function. Okay, that exit off of that brainstem. So they are going to do those tests. The other thing that they can do is a cerebral blood flow study to see how much blood is getting into the brain. Zero blood flow into the brain equals brain. Okay? Because sorry? The ice water calorics, yeah. Again, that is a cranial nerve stimulation. Like I said, they will do that occasionally to check 8th cranial nerve with people with problems with balance. They don't stand for them. Because if they're awake and alert, they're going to throw up. All right, so I think we've pretty much rehashed ICP. What do we learn about meningitis? Which one's worse, viral or bacterial?
Bacterial.
Okay, what do we as nurses have to be concerned about? The ICP, yeah. Confusion. What else? If I get a call and said EMS is on the way with a patient with meningococcal meningitis, what am I going to do?
Droplet precautions.
Droplet precautions. We're going to put them on a respiratory isolation. Meningococcal or Neisseria meningitis. Those are the two that have to be respiratory isolated. And typically you're going to have to respiratory isolate them until they've been on antibiotics for 24 hours, okay? So, anything else about meningitis that we need to worry about? Why don't we see meningococcal as much anymore? Vaccines. Okay. Usually they get it around 10 or 11 years of age. If they have not gotten it at that time, it's always a good idea to get it prior to going to college, because remember, it's areas of high concentration of people in a little bitty space, dorms or army barracks or, people that are in service. We don't know yet, because think about it. The vaccine actually came out for widespread use around 2001, okay? So right now we've only got 16 years of data. So we don't know. So it may be that when we reach that 20-year mark, and they call my daughter and say, well, would you give us a blood sample because you were in the original study to see what your, immune system is doing with this? Help her, because with vet school she had to get rabies vaccinations too. So she has to check a rabies titer every 3 years too. But we just really don't know. They'll probably do another study at 20 years and then every 10 thereafter. So we'll see. But typically what you're going to see is meningococcal. We most often see it in the younger age groups because that's where they cluster. I've not seen it very often in nursing homes or things like that, unless they've got a lot of kids that come in and visit as well. But we really don't know what the long-term effects are going to be. It may be that, we will have to do a booster. Okay? And that's one of the things that we found with the MMR is that people that got it the year that I was born had to have a booster at 20 years or on the chance of exposure. Yeah. So, we'll see. All right. Anything else about meningitis? What about...
If there's a rash that doesn't disappear under pressure, it's the bacterial.
Right. It's meningococcal rash. Okay? No, the others do not produce a rash, and so that's pretty diagnostic. Purple blotches are never a good thing, but meningococcal, they do look like purple blotches. You may see the septic emboli. Okay? All right. So CSF leaks and basal or skull fractures. We talked about that yesterday. What's one of the signs that you might see? Raccoon eyes or the battle sign. You may also see CSF leaks. Okay. Took care of this guy one time that had a CSF leak. He was an electrician. And you know how particular people are about their tools. Well, he was up on a ladder doing a floodlight. He put his screwdrivers in his pocket with the pointy part up, gets down the ladder, and he falls the last 3 rungs and basically did this. And that screwdriver went straight up his nose.
God.
And he punctured the base of his skull and got a CSF leak. And it was one of those things when basically he lay flat in the hospital and we had to put a lumbar drain in to lower his pressure. And he stayed that way for 2 weeks in order for it to heal. And when I was doing his discharge instructions, I said, okay, now this is what you need to look for. Now, when are you going back to work? What have you learned about your tools? He said, throw them on the ground. I said, yep. You can pick them up a whole lot better than you can pull them out of your nose. All right. So, CSF leaks can be a little bit of a problem because infection is one of those things. Because if you think about the nose, what does it do? It filters bacteria from the environment. That's what those little nose hairs are for. And those of you that pull them all out increase your risk of infection. Tell it's through CSF by glucose test unless there's blood in it. Okay? Then you do the halo test. The blood, if you put it on a white pillowcase or a white piece of paper, okay, and use white, because what you will see is that the CSF will form like a yellow band. The blood will clump in the middle. You just basically take a drop and see what it does. Okay? All right, let's talk about head injury that we started on today. What do we learn about head injury? On the rise? Okay. What are some of the major causes?
Sports injuries.
Sports injuries, falls, motor vehicle crashes.
Increased ICP or hypoxia is a secondary.
A secondary injury can be caused by hypoxia. And that's one of the things that we can really treat or try to treat. Okay? Remember, hypoxia is caused by what?
O2.
Low O2. So as a nurse, one of the things that I'm going to do when I'm doing my assessment is airway, breathing, circulation. Okay? Protect that airway. Are they breathing adequately? It never hurts to put O2 on somebody. So I will tell you with my head injuries, it's face mask. I never do nasal cannula. Because if they've got a basilar skull fracture, what did I tell you that we call people that are airheads? Pneumocephalic. You can get air into the brain from that basilar skull fracture. Okay. What else did I tell you about basilar skull fractures with nursing?
Never put anything in the nose.
Never put anything up the nose until basilar skull fracture has been ruled out. That nice little picture of that NG wrapped around somebody's frontal lobes. Not a good thing. It's crazy. All right, so are we up to where we left off? Pneumocephalic. That's what you call your brother. I did. What's CTE? Right. Basically, it's caused by continued concussions. Doing some further reading last night, and basically one of the things they were saying is that there are a lot of parents as well as medical folks that are really pushing, especially in young kids, for them to wear helmets during soccer. Because what we have seen is a 50% increase in concussions with people playing soccer, not only with heading the ball, but cracking their head against someone else's head. Okay? If they lose consciousness, they should always come out of the game and always be evaluated by a medical professional. Not just the guy at the side of the, oh yeah, you're all right, going back in. Because what they're finding is that about a third of the people that do have concussions are sent back into the game. And further concussions can cause major damage. And even though they're kids and they usually heal, repetitive head trauma can cause major damage and basically cause some difficulty with learning. Okay, so we talked about epis yesterday, epidurals above the dura. It's not a usual space. So what this does is it separates the dura from the skull. It's arterial. And remember, classic sign is that loss of consciousness, lucid period, and then rapid deterioration. If these people are not treated, they die. Usually caused by damage to the temple bone. Now, subdural hematomas. Remember, this is a space that we normally have a little room. Okay? So what you will see is that there are three types. There are acutes that basically show signs and symptoms within 48 hours. Subacute, 48 to 2 weeks, and then chronic, over 2 weeks. What you see here, this is a large subdural, okay, right here. And what you will see is, see how the brain has shifted over so that your ventricles here on this side are almost obliterated. They're clamped down. So this patient is probably showing a little bit of herniation because you can see part of this brain has shifted over. See this little mark right here? It should be straight. If it's not straight, that's cingulate herniation. So this patient is probably showing signs and symptoms. Now, with acute subdurals, we are going to see that those people are going to show signs and symptoms fairly quickly. A lot of times what you see with these acute subdurals are a little bit harder head injury, okay? Or these are your people that are on anticoagulants or antithrombotics. Even though this is venous bleeding, okay, what you see is a rapid decrease in that level of consciousness. It can be immediate, or that can slowly decrease over that 48 hours. Depending on where the subdural is, okay, in this person's case, it's near the frontal lobe. So what I would see is not only a problem with decrease in level of consciousness, but the functions of the frontal lobe are going to be altered. That's why it's important to know what your brain anatomy is and what those lobes do. Now, subacute bleeds, we see this a lot in the elderly. It takes 48 hours to 2 weeks. This is more of a slower ooze. It also, we see it with chronics in elderly clients as well. Why? The brain atrophies. So what that means is there's a whole lot more room for your blood to accumulate without showing those increased intracranial pressure signs. I will tell you another population, your alcoholics, for chronics and subacute. Because alcohol kills 2 million brain cells for every ounce. So think about that this weekend before your test on Monday. Per ounce.
How do I have a brain left?
Yeah.
How do I have a brain
It's
left?
not unusual. I had she said she got hers in a 4-wheeler wreck. I had one of my nurses at Duke, they had this bright idea, instead of having IV poles in our ICU, they would hang them from the ceiling and you could push a button and pull it down and then work whatever you needed to do and then push it back up to the ceiling. Well, one of the nurses left it down and she went down to empty a Foley catheter and came back up and hit the top of her head with that IV pole. Knocked her out.
I'm done.
She developed a subdural from that, and then they quickly re-engineered the IV poles. So, basically what you're going to see is subdural hematomas. Now, how do we get rid of these things? Typically what they do is a craniectomy, okay, or craniotomy, depending. Now, if I have got either an acute or subacute, most of the time what I can do is just open a little hole, stick a catheter in, and suck the blood out. But if I've got a chronic subdural, sometimes it takes up to 6 months to a year for those to develop. They calcify over, so you really have to do a craniotomy to peel those off the brain. Okay? So the blood is removed. It may be slurped up if it's still sort of gooey, but if it's hardened, they really have to go in there and peel it off. But typically what you're going to see with these patients is you watch them for further bleeding. Because it's one thing about the brain, if you take something away, that brain's going to try to re-equilibrate that ICP, some more blood's going to come into the brain, and you may have further bleeding. Okay, so they can reaccumulate. Yeah, pretty much all of them. Chronics are less likely than your acutes, but all of them can. Now, intercerebral hemorrhage, intra, meaning within the cerebrum. Intercerebral hemorrhage often is caused by either rupture of an artery due to trauma or aneurysm or stroke, we're going to see in a little bit, But a lot of times you will see intracerebral hemorrhage from penetrating injuries, like gunshot wounds or knife wounds or baseball bats upside the head. But intercerebral hemorrhage, you have tearing of those small arteries and veins in the white matter. Of the three types of head injury, this is probably the most dangerous, because what it does is it causes significant brain edema and increases in ICP. So, with the warning signs after head injury, changes in the level of consciousness, increased drowsiness, increased confusions, and difficult to arouse. Now, how am I going to try that arousal? Going by looking at my Glasgow Coma scale, what's the first thing that I'm going to do after I walk in the room and they don't turn their head and look at me?
Verbal.
Call their name, okay? And if they don't respond to that,
Painful.
touch, okay? They don't respond to that,
Painful stimuli.
okay, painful stimuli. Let's talk a little bit about that. What's the best way to give pain?
Sternal rub.
You can do sternal rubs, okay? But I'm going to tell you that after a while, basically, if you take your pen and just do it right now. Take your pen and put it on the base of your nail and push. Okay? It doesn't look that painful to the family member. You start rubbing grandma's chest, grandma's going to have a big old bruise. And family are going to complain. Basically, I like to do nail bed pressure because if I've got a patient that is not responsive on one of my limbs, I can surely tell it. Sternal rubs basically give you a generalized whatever. They wiggle in the bed. But if you give nail bed pressure, they will withdraw. That is a appropriate response. And you can do it all 4 limbs and see what the response is. I can tell if they've got movement on that left side or that right side with that kind of response. Now, I know your book says supraorbital pressure, like taking your thumb and pressing above the eyeball. Don't do that. Well, I wouldn't like it either because number 1, it raises ICP, and number 2, you don't want to pop their eyeball out. Because some of these people have head injuries, they may have orbital fractures too. The other thing you can do is the Mr. Spock pinch, okay, where basically you squeeze the trapezius. Again, that's a central pain response. But they'll move if you pinch them hard enough. Again, it relieves some bruises. So, nail bed pressure is probably the better way to do it. I will smack your hands if I ever see you do a nipple twist. I have seen nipples twisted.
Oh.
What? A lot of the
What an idiot.
docs will just go in and take a nipple and twist it to see what the pain response is.
What would it take to take it off?
We had one doc do that, and the nurses ganged up on him, and went to the attending physician, and he never did it again, and he apologized to the family. Well, I've seen nipples twisted off and have to be reattached because of that. So, do not.
When I broke it down, did you there and I was trying to find out? It makes me really scared. Like, what if he just like told me, like, don't be turning on my thing while it's on me? I don't like to touch anyways, but
I don't know. Because a lot of the older docs do it sometimes, but it's not appropriate. Male or female. Yeah. All right. Some other things that we'll see: people slow or to react or unequal. Okay. Remember, cranial nerves are same side. So if I've got a pupil that's getting slow to react or getting larger when it's previously been reactive, that's a change in neurostatus. It needs to be reported. Visual problems, loss of sensation to any extremity, slurred speech, projectile vomiting. Like I said, it's without nausea. Seizures, bleeding or drainage from the nose. So, why are these warning signs? What do these tell me about what's going on in this little guy's head?
ICP.
He's having increased ICP. You don't see that in your unconscious patients, and that's the only reason we test it. Yes.
One of the first semester I had a patient that nurses were saying that their eyes were perfect, and then whenever I was looking at one of his completely dilated, he said he had a brain injury before. They normally say.
All right, 17% of the population have unequal pupils.
Oh no, this was like.
I'm serious. Some will be 2 and then some will be 6. 17%. That's why it's always best to know which baseline is. Now, I would be concerned about this guy if he had previously equal and reactive pupils and now had gotten a large one. But this is where it gets sticky and everyone else close their ears. There is a syndrome called Horner syndrome, and you will have fluctuations in pupil size because of Horner syndrome, but that's fairly rare.
He actually,
As long as he's awake and alert and talking to me, I wouldn't be as concerned.
I was like starting to freak out, and he goes, "Oh, this is like that."
Yeah. I mean, the thing is that look at that level of consciousness. Awake, alert, and talking means that they've got good brain function. If they're making sense with their talking. Pupils are a later sign. Okay? Yes.
Oh no, I'm stretching.
Oh, okay. All right. So, ICP is going to be your problem. Now, some of the nursing diagnoses that we're going to see, and I'm going to hold off discussion on these because tomorrow we're going to talk about all of these folks as a group. Because think about it, if increased intracranial pressure and damage to that brain is what's caused with all of these situations, why would I want to tell you 15 times this is how you care for this patient? We're going to do it once, and you're going to get it, and it's going to be good. But these are some of the diagnoses that you would see. Ineffective airway clearance, impaired gas exchange. Remember, oxygen is a good thing, and that damaged brain needs probably a little bit more than what room air is. Okay, anyone know the percentage of oxygen, inspired oxygen in room air? 21. Okay? So, basically, if you're giving someone oxygen, you wanted it either 30 or 40%. So 21 is what they get normally whenever they breathe in and out. If they're adequately breathing in and out. Okay? Deficient fluid volume, risk for injury, risk for imbalanced body temperature. One of the things I did not talk about, but one of the things that you may see with some of your head injury patients is what we call hypothalamic syndrome. or hypothalamic storms, you may hear it referred to. Remember, the hypothalamus basically controls temperature regulation. If you have damage to that, sometimes these patients will spike temps to 105. But they're not infected. It's not due to infection, it's due to altered thermal regulation. I had this little guy, he was, I think, 21 years old, motorcycle accident. The guy was a bean. He was probably 6'3" and weighed 130 pounds. Okay? He unfortunately had a severe diffuse axonal injury, which meant that he was unconscious and probably would not recover because it was throughout the brain. But he also had damage to the hypothalamus. What happened is that we were caring for him, and all of a sudden we see his temperature, it peaks at 104.6. And of course we do the fever workup and the whole 9 yards, and he's clear. And what we started noticing is that whenever he was stimulated a lot, okay, he would have these fever spikes. And the doctors got all excited about, oh, this is a paper. And I'm thinking, yeah, it's a paper, but how are we going to treat this guy? Because think about the 6'3", 130-pound guy. Whenever his temp would spike, we would see blood pressures of 220 over 120, pulse rate of 220, respiratory rate of 40, and that temperature. Basically, we had dietary to come and do a nutrition consult on him. And with those cyclical patterns that he was doing with that rapid metabolism, she calculated that this guy needed 10,000 calories a day to maintain that 130 pounds. There is no way on God's free earth that you can get 10,000 calories in someone through tube feeding. I mean, I don't care what you put in it. There's no way. Because most tube feeding, even the high calorie, most tube feeding has 1 calorie per 1 ml. The higher calorie ones have 1.5 calorie per ml. Okay? Even if you add protein and all sorts of stuff, you couldn't reach anywhere near what this guy needed to maintain his weight. Now, any of you ever initiated tube feeding on someone? Okay. Start the feedings. Okay. What usually happens after you start giving them this tube feeding, if it's one of those higher calories, you have code brown from the word go. Okay? The higher the calorie intake with that tube feeding, the more likely it is to pull in water from the body and cause massive diarrhea. So those are some things to think about. We could not keep this guy at his birth weight without getting rid of those storms. So what we had to do is figure out a way to dampen the effect of this hypothalamus. Well, what we gave him was bromocriptine, Parladil. Used to be a drug that they would give to women after birth if they were not going to breastfeed because it would dry up milk. Okay, because what it did is it decreased that letdown reflex that you get with the oxytocin and the whole 9 yards. But it took a while for that Parladil or the bromocriptine to work. They don't give it to women anymore because there was a case where this woman took Parlodil, killed her husband, and blamed it on the Parlodil. So it's no longer an indicated use. You get cabin fleas and a broth. Alright, so anyway, it took almost a month for this Parlodil to achieve the effect. What we found out after searching the literature for minimal information, that 4 milligrams of morphine at the start of one of these seizures given IM would break it. And so that is the only way that we got this guy to maintain his weight. He still lost 10 or 15 pounds until we figured it out. And during these storms, he would become apostonic, which meant that his head would touch the bed, his heels would touch the bed, but I could take my hand and do this underneath him. So where do you think that he had skin breakdown? His head and his heels. So think about nutrition for these patients, especially with these patients with head injury that are having altered bodily function, altered metabolism, because people cannot heal unless they get adequate nutrition. Okay? Impaired skin integrity, disturbed sleep patterns, interrupted family processes, and then deficient knowledge about brain injury recovery and rehab process. And this is one of the things that families have the hardest time with. Those people will never be the same. They may recover functionally, but often there's some change in personality, often some change in the way that they function. Now, it depends on the level of head injury. Mild head injury, concussion, those people often do what they can do and have no problems. But every concussion thereafter raises the risk of them having permanent damage. Okay? Tell you what, let's take a breath.